So we're going to, in the interest of time, move on to this session, Women and Heart Disease. And I have two very distinguished speakers here, Professor Dr. Karin Schenck Gustafsson from the Karolinska Institute, and she's going to give us a presentation on the subject of women and cardiovascular disease. And then we'll be inviting Celina Gorre, who is CEO of WomenHeart in the US, National Coalition for Women with Heart Diseases, to speak from an advocacy point of view and the work of her organization. So without further ado, I'll hand over to Professor Gustafsson.
I've been there many times.
So, we'll let you go first.
So,
It looks like it's my print.
so where are my...
Not that I'm very technical now. I'll close out of this. And
That's the
So what is
the
the
other
name
one.
of your one now? Would you know it there? Can you see it?
Try that.
This one, is it?
Or Stockholm.
This one, is it? Is that yours?
Nej, Stockholm. Nej. No.
No? Okay. Stockholm, this one?
No.
This one? Okay. So,
WomenHeart, perhaps. No.
That's... I doubt if that's your one, is it? I'll try this.
No.
No?
Yes.
Is that you?
Yes. Yeah, that's me.
Okay. So, we go...
But that I don't know who that is.
But are these your slides, though?
Yes.
Karin, did you create a slide deck here? No? No, so I'm just wondering. Anybody from technical?
But I can start with that you
Can
had.
you? Yeah?
What did
Okay.
you have?
All right.
And that's me. And that's another one.
Yeah.
So
Who
that-
created this slide deck, I wonder? You don't know?
This is you.
Yeah. So this is you, is it?
Mm.
Okay. So we'll just enlarge it there. Yeah. Okay, and there's the
You
Yeah.
can tell me.
you can go, yeah.
Okay.
Yeah.
So, hello everyone. I've been a bit confused and I didn't know where to speak, but now I think it's here. So, I'm going to give you a 10-minute lecture about women's heart disease. And konstigt. Sorry, I have to do this. In 2001, jag ska ha...
I'm trying to get rid of that for you.
Here, in 2001, the Institute of Medicine in the US published this exploring the biological contributions to human health. Does sex matter? And of course, sex does matter in any speciality and in other ways also. And already in 1991, I got inspired by this article in New England Journal of Medicine, one of the best journals ever. And it was from the CEO of NIH, Bernadine Healy, and she was a cardiologist. And she talked about the gentle syndrome. And what she had discovered that most clinical trials from FDA and other, also NIH, didn't include enough women or no women at all. So she wondered, do women have to disguise as men to be treated properly? And that is a bit of the gentle syndrome which Barbra Streisand participated in the film. And actually she founded a Center for Cardiovascular Disease in women in LA. One of my friends, Noel Bailey-Mertz, got a lot of funding from Barbra Streisand after this film. what about myocardial infarction? If you look, you have differences, sex differences in almost every cardiac disease. And if you take acute myocardial infarction, that's the most common cause of death both in men and women. And what you see is this picture of a man having chest pain, and it's always like that. But women can also have myocardial infarction, but 50% of women don't have the typical pain. Instead they can have dyspnea, tachycardia, and general disease feeling, and this can explain some of the clinical thing I will present to you. Women have longer delay in contacting healthcare when having a myocardial infarction, and it's shown in several both Swedish and other publications. And one reason is, of course, that the woman don't have the typical symptoms, and the woman herself doesn't know that she can have myocardial infarction, and also the patient, the staff at the ER don't know, and then you have this long delay. Also, more men get ambulance prio 1, that is advance, when they call the ambulance central and telling that they have some chest pain. And then it's for women, it's prio 2 or 3, and that is 20 minutes or several hours. Prio 1 is advance. And it's shown in Sweden and also in America. And women have lower chances than men to be resuscitated and survive out of hospital cardiac arrest if you get a cardiac arrest in the street. And that is from a Dutch study recently published. And it has to be some more studies here also to verify. Also, if you look at the pathophysiology of myocardial infarction, it's not the simple thing as a coronary stenosis. It's in the upper side you can see a coronary stenosis, and that is both men and women can have it, but it's much more common in men to have it. Women, women have more often than men so-called normal angiography when having myocardial infarction. And the thing is that everything is in the peripheral. It's microvascular disease. And the common cause of that is long-standing hypertension. Women have smaller vessels and therefore more prone to have vasospasm. And if the vasospasm in the coronaries endure more than 15-20 minutes, it can be a myocardial infarction. And also women have special forms of myocardial infarction, for example, coronary artery dissection, SCAD. And also Takotsubo, it's when they have extreme stress, and that is much more common in women. And then the heart can't pump as it should do. Also, as it comes to heart failure, there are evident sex differences. And if you see the blue figure to the right, that's the man. And he has the type of heart failure that we call HFrEF, that is reduced ejection fraction, the left ventricle doesn't function as it should. And you have also a milder form, and that is much more common in men. And if you look at the red figure, you have HFpEF, that is heart failure with a preserved left ventricular ejection fraction. That is when left ventricular pumps normal, And it's still a mysterious thing, but it's much more common among women, up to 70% women and 30% men. And when you look at the articles, the women are very few in the articles about HFpEF, and also about if you take the new anti-diabetic drugs. 30-40% women with the new diabetic drugs having a very, very interesting and good effect in heart failure, which is something very new that has happened in the heart failure field. Also, men and women handle drugs differently. It's the pharmacokinetics, that is absorption, distribution, metabolism, elimination. And traditionally it's said that there is no difference. But we have seen that in our research that there are differences between men and women, which might have an impact in the dosing and also the side effects. And then you have pharmacodynamics. And there you have certain drugs prolonging the Q2 interval on the ECG, and that means that they have a higher risk of getting ventricular arrhythmias and also syncope, Torsades du Pointes syncope. That's much more common among women, and there are also other examples of this. We also know that women have different side effects. They have more side effects, and they take more medication, and also their bodies differ from the men's body, and they handle the drug differently. So if you are interested, you can look at our knowledge base called www.janusinfo/sex. And there you can write down a drug's name, and then you get our answer if there is any important differences between men and women when taking this drug. The research councils in Canada and the US, they since many years they have sex and gender aspects in the research applications. It's mandatory, and if you don't get any money if you don't have a sex and gender aspect in your research application. In Sweden we got it 2019. So our Swedish Research Council demand this, but still it's not good. And just recently, in May, there was an article in New York Times and saying why heart disease in women is so often missed and dismissed, and it's from an article. And also The Guardian from another article. Lack of research on heart disease in women is risking lives, says experts. And you can understand that, of course. And very recently, Professor Nanette Wenger from Atlanta was the first author in this circulation paper. And they are calling to action for cardiovascular disease in women, both epidemiology, awareness, access, and delivery of equitable health care. So we are international. There is a lot of discussion, but I missed that discussion in Sweden. There is no discussion in Sweden about this. And recently, I was referring to the new anti-diabetic drugs, which is very good for the heart when you have heart failure. And Eugene Browell, who is the godfather of cardiology in the world, he is a professor in his 90s from Harvard, and he was commenting one of the diabetic studies and saying, and the next step is to look at women and other subgroups from him. And then I got angry, of course. One big help I have had is from the NGO 1.6 Million Club. We have something called Women in Red programs, and since 15 years now, every spring we are in almost every city in Sweden talking about women's heart disease, and we have a lot of good speakers. And some of these speakers come from our scholarships. I'm chair of the foundation, Women's Health Foundation, and we deliver scholarships for young investigators, young researchers, just before the PhD thesis or just after. Because I've noticed since a long time ago that it's there we lose a lot of young, talented researchers, and especially women. They stop doing research after their PhD thesis. And now we can give them some support so they can continue. And it's one of my most... it's a very nice job to be CEO, to be chair of this foundation. And this is from the other year, and we have a big gala when we give them the money, and always we have some politicians there. And to the left you see Alexandra Charles, and she's the leader of this 1.6 million club for women's health. And I noticed that the man there, he's a thoracic surgeon from the Karolinska, and he wants to look at the results from cabbage after and comparing men and women. So this is a very nice thing you can do, and also to reach people in the real world, to reach patients, and to also to inform them about the fantastic research that is going on. And these are also some of our speakers at this Women in Red campaign that we have every year. So I will just end up with, this is the Kvinnohjärtan is Swedish, and it means female hearts, and it's an anthology where a lot of cardiologists write about women aspects in every cardiac disease. And I have also the main editor for this handbook of clinical gender medicine, together with a lot of Americans. So thank you.
Thank you very much. Thank you very much, Professor. Do you want to take a seat here? Mm-hmm. So clearly you've heard here of the differences between men and women in heart disease, and of course this is quite significant, because when you go to the general public and you do a survey, you find that very often people are not aware that there is this gender difference, and many women are surprised to learn that actually more women die from heart disease than from breast cancer, and so there is a need to raise awareness. But more importantly, the question is, in relation to this sex difference, is there actually a sex bias or sex discrimination? And I think for that reason, you'll be interested to hear from Celina and her organization, who are advocating for greater awareness of these differences, and as I say, looking at where bias is appearing in terms of healthcare. Celina.
Oh, great. Well, thank you, everybody, and good afternoon. It's such a beautiful day in Stockholm, and as my friends like to remind me each time I visit, this is not all that usual, especially in October, so take advantage of it. Today I want to give you just a bit of an overview, following Dr. Karin's great presentation, about what WomenHeart does in the US to turn patients into advocates, but we like to call them champions. And I want to share the experience of WomenHeart, not because this is the roadmap, but that this is one organization's experience with how to activate patients to really enable them to share their stories to make systematic change. So WomenHeart was founded in 1999 by 3 women who had really unacceptable experiences in their journey to be diagnosed with heart disease. They were dismissed, and I was speaking at lunch with some women about how many women have had the experience now around the world to be sent home with anti-anxiety medications in the process of their heart attack. And so this is a story that we hear time and time again. So at our core, WomenHeart is a social justice organization, and our mission is to improve the lives of women living with or at risk of heart disease while fighting for health equity. And this line about health equity is really at the core of all that we do. So this is from our website, and it is sort of a very quick snapshot of the patient's journey as they travel through WomenHeart. In order to get to the place of engaging patients who are ready to be champions, to use their voices in amplifying their stories and their messages and their experiences to change systems and policies, WomenHeart starts from where the woman is. And often that means enabling and encouraging women to get a handle on where they are as a patient and their identity as a patient. And before we even do that, the women themselves have to be ready to have that, to embark on that journey themselves. We all want to start at the far right side of this, or left side of this this continuum in prevention, but the reality is that most women come to WomenHeart at the point of diagnosis. And that means that they're struggling with what it means to be a woman living with heart disease. I know earlier Magdalena and Neil talked about prevention, and when we talked about ASCVD, but it more often than not, they already have been diagnosed when they enter our doors. And we want to take them on this journey through to thrivership. And at that point, they have accepted their condition, but also they're ready to help others in their own heart disease journey. Now, once a woman decides to become a champion, they submit their application, and we interview them and look for some key aspects of their application. Do they have leadership skills? Are they ready to commit to serving their communities? And importantly, are they medically cleared to take on this commitment? Because it's quite a big commitment. In fact, on Friday, I'm going to the Mayo Clinic in Rochester for our 2022 training of our new champions through our Science and Leadership Symposium. And during this time, what is incredible to see is that there is some real cohesion that happens. It's not just a bunch of individual women that come and get trained and go home. They come away with a bond like I've never seen before, and they have heart sisters, and they are, the way they relate to each other is just incredible. And so I've never worked before for an organization where the volunteers call each other heart sisters. Now, this is a really quick snapshot of where we are across the country. And you can see we have pretty good coverage. The light purple is where we have champions, and we've got champions in 45 states. The darker purple is where we have support groups, where our champions run these groups, and we are in 33 states. And then the darkest purple is where we have National Hospital Alliance members, in other words, hospitals that have wanted to commit explicitly to taking action to make the journeys of women who have heart disease a better experience. And through the pandemic, unfortunately, or maybe fortunately for us, we had to pivot to virtual platforms, and Sister Match is one of the ways that we did that. Women who have had the experience of being diagnosed with heart disease and want to connect with a peer can download our app, and I like to call it Tinder for heart disease, because they get to match themselves with a big sister who can provide that one-on-one support. And it's actually been a really great way for us to reach women during a time when in-person activities went pretty quiet. So once the champions have been trained, they go back to their communities, and WomenHeart continues to provide them with support. We have, obviously, as I mentioned, support groups, but we also run regular heart talks, which is our webinars, as well as sessions called Ask the Cardiologist, where they connect back to Dr. Sharon Hayes, who's pictured here, to be able to continue to ask questions of her about their own specific heart journeys. And then I want to talk about what happens when they decide, when a patient or a champion decides they want to become an advocate. Because that is not, we don't presume that women automatically want to be advocates. That's a special level of training, and they join our advocacy corps. And once we've informed them and they feel like they're ready to take ownership of their heart disease, they go through these phases of advocating for themselves and then for their community. And then the ones who are really excited and passionate get invited to come to Washington, and they advocate on the Hill, Capitol Hill, and are able to use their stories to really move policy along. And Dr. Nanette Wanger, as some of you, who some of you may know, is really the godmother for women and heart disease. And she often talks about these different stages of how we involve champions. I mean, we started off at the very beginning of this day talking about the need for more patient engagement in clinical trials, and that's really investigation. But once we have captured the attention of patients, it is our obligation to educate them and to make sure that they have the adequate information necessary to go back out and empower not just themselves, but their others in their community. And then obviously that legislative change and systemic change is what we're after. And here you can see, this is a picture of one of our Hill briefings on Capitol Hill, where our patient advocate here is speaking about her experience of heart disease and pregnancy. And so there was an act that was passed not too long ago that really addressed directly some specifics around making sure that there are regular heart disease checks when a woman is pregnant. And I've already talked about Advocacy Corps as a really important component of how our women heart champions are activated to really change policy. And what's fascinating to me is that oftentimes these policymakers don't want to hear from me or Neil. They want to hear from patients. They want to understand what it means on the ground in day-to-day in a patient's life. And, to me, advocacy is a means, and what's the end? And in our world, our end is health equity. And so we look through everything that we do across our organization to ensure that we always have at front of our minds the idea that all of our services and all of our materials are accessible and available to everybody who can use them. And then this last end is really bringing together the research community to ask the question, what does it mean to address directly this idea of delayed and misdiagnosis that Dr. Karin talked about? Why is that happening? And we want to research that. We want to understand that better because it's happening far too often for our taste. And I want to leave you with one question, and that is, as a global community, what would it look like for all of us to work together to address the issues that are specific to women with heart disease? I've been having conversations with Neil and the team at the Global Heart Hub about how WomenHeart and the Global Heart Hub can bring organizations together. And so I'd love for all of you to consider that. And if you've got any ideas about how we can use the power of our collective voices to change policy for women, I'd welcome that conversation. Thank you.
Thank you, Celina. So conscious of time, we've literally 1 minute. Would anybody from the floor like to ask a question of either of our speakers? No? Maybe I just ask one of you, Celina.
Sure.
In the context of what Professor Gustafsson was outlining in terms of the many differences and the issues,
yeah.
From an advocacy point of view, what are the sort of priorities that WomenHeart are currently working on? Is it misdiagnosis?
It is misdiagnosis, because that covers such a range, and we also know that it's not just in heart disease that we have misdiagnosis and delays. And so there's something systemic about how women are treated in the healthcare system. And again, learning that it's not just in the US, it's here in Sweden, it's in many places around the world. So there's something about that we really have to fix. And if we do that, then we can tackle so many other things. But we are constantly underrepresented, underdiagnosed, and our outcomes are worse. So there's something that we've got to do to raise our voices to make sure that we're heard.
Yeah. Professor Gustafsson, any final comments from what you've heard?
I think that, do you hear me?
Yes.
I think it might have been a little better, at least in Sweden, but not enough, and we have a lot of things to do. But at my hospital, Karolinska University Hospital, even the thoracic surgeons know that might be a difference, and they, when they do research, they look at it. So on a local level, I'm satisfied, but not on a general level.
Yeah.
Because you have to be there all the time to remind them. And if you aren't there, they forget it.
Yeah.
So it's better, but not good. A lot of things to do.
Yeah. Interesting, isn't it, that something so fundamental, and there's a gender difference, and it doesn't make sense, really, does it, in terms of that how there's a different perception. And from a research point of view, same issue here, women underrepresented in cardiovascular research in Sweden.
Absolutely. And when you get, for example, when you get this fantastic new drug in heart failure, SGL2 inhibitors, which is a diabetic drugs, but it functions very well for all types of heart failure. Then in the studies, the women are underrepresented in spite of being having the prevalence is much higher.
Yeah.
Still, they are underrepresented. And this is another thing to at least some say that it's more difficult to recruit women in clinical trials. I don't know. I haven't that experience, but there is a general people think so in general, and it might be in some countries, but not in Sweden. So
yeah.
I think we could have a whole conference on how clinical trials are run and why women are not part of it more.
So as you alluded to, from the Global Heart Hub point of view, we're obviously going to be looking at this and see, can we, through an international alliance, try and create a higher profile, because clearly it's a lot of important questions to be answered. Conscious of your coffee... Oh, yeah, sorry, yes, a question.
Hi. I'm just wondering, because it was really interesting to hear about the Global Heart Hub and your app. Is it possible for other countries to use it, or?
This is a great question. Come and see me after, because one of the things that I'm trying to do is understand where national boundaries matter and where we can blow right past them and not care. And that's one of that's a great example of a question we would be trying to answer in the context of this collaboration. So now that you've formed your brand new organization, please join us and help us think that through.
I think we could reach out to more people.
Absolutely.
I think you could do something in Sweden and work with you. And I know some of your, Nanette Wenger, for example, and also Sharon Hayes.
Yes, Sharon Hayes,
I know
Dr.
them.
Barry
I know them.
Murs. Yes, all of your friends.
Yeah, a lot that we can do. We'll leave it at that, as it's coffee break time. Can I thank you and ask you to show your appreciation for our two speakers, Professor Gustafsson and Celina Gorre. Thank you very much.